All right, we're going to go ahead and introduce Dr. David Klingman so he can go ahead and walk you through environmental workplace safety, infection control, and risk management. Dr. Klingman, without further ado, the mic is yours.
Okay, is everybody hearing me and seeing my slide screen?
Loud and clear.
Okay, so thanks everybody for being patient. All right, again, Dementors are gone, Elder Wand's broken. All right, this one's a little bit lighter in terms of topic, and we're going to try to come back and answer some of the other questions. I'll try to come up with some responses during Dr. Kroll's in the background. Okay, so a little bit about environmental workplace safety, and I know I'm going to get some questions about COVID, and I know I'm going to get some questions about sterilizing, so I did some dives into the CDC website, and we'll try to catch some facts towards the end. All right, disclaimers, same as before. These are my views and not the views of anybody else, and I don't get paid by anybody else but the people who pay me. All right, so what is our setting, right? It's about us, our patients, the places we work, and the environment that we live in. And we're going to talk about all the regulations and all the recommendations in those contexts. So again, my MacBook loves to do strange things to my handouts, but the handouts should be nice and neat. So we're going to try to talk about all the agencies. We're going to talk about, communicable diseases, the precautions we take, the devices we use, and then obviously the processes that we put into place when we have something happens. All right, so let's talk about the agencies first, and we're gonna couch this into regulatory and non-regulatory agencies when we get to this, and we're gonna talk about guidelines, recommendations, and things that you actually have to do because they told you to do that. But let's start talking about infection control. Two major organizations you need to be aware of. One is OSAP, one is AAMI, right? These are the folks that define what our infection control standards are going to be, all right? The important point here is that compliance is the minimum standard. Anything you do above and beyond that is up to you as long as you meet the minimum compliance standards. So I'm not going to spew out all the minimum standards because we'd be here for 7 days. But I think you guys have to be aware of what OSAP and AAMI say. But these are the folks who define things like the universal protocol for those who use it, right? This is the pre-procedural verification. For those of us in the military, we do some site marking, and then we obviously do the so-called timeout procedure. These are the folks, OSAP and AAMI, who define these things. When it comes to the agencies themselves, you have to know who regulates and who doesn't. So OSHA, FDA, and EPA, what they say, we have to do, right? There's no question. There's no arguing with it. It's a requirement. CDC and ADA only make recommendations. We're not obligated to follow their rules. We tend to because they're usually pretty wise rules, but you need to know the differences. Okay, so let's talk about OSHA. What's OSHA's job? That's to protect you and I, right? The people working in the workplace, to make sure our working conditions are safe and healthful, right? Some local and state agencies will have inputs to this that will supersede OSHA. So you just need to be aware of what your local stuff is, right? So based on the map, I'm in Texas, right? Federal OSHA rules, right? For the folks, say like Chris and those folks who were at the AGD headquarters in Chicago, right? There's a combination of state plans that are OSHA approved. And then there are some areas that are, that are only state only, okay? All right, so what does OSHA say we have to do? Number one, workplace has to be safe. Number two, what all these highlighted things boil down to is we have to put information up that informs our workers, provide them training, address injuries, illnesses, and any tests we might need to do in order to do that, provide them with PPE and the exams that are going to deal with things like their hearing and their musculoskeletal disorders. And then if there's an event, we have to notify OSHA and we have to have the workers have to have an opportunity to have a say, right? So this is what the poster typically looks like. This is off of the OSHA site, all right? OSHA tells us to post these. All right. So who else covers OSHA standards? It's actually construction, industry, maritime, and agriculture. There is no specific OSHA standard for dentistry, despite what anybody says. But any workplace that has a biological, chemical, environmental, physical, or psychological workplace hazard may apply, right? So for us, obviously, we deal with biologicals, right? They're called patients. We deal with chemicals, they're called materials. We deal with environmental, we're going to get to mercury and amalgam in a bit. physical, right? Carpal tunnel in our hygienists and our folks who are doing cleanings, and then sometimes us, and then our obviously musculoskeletal type things. And then obviously right now psychological is everybody, right? Because everybody's kind of afraid to come see the dentist, and dentists are afraid to have patients come see them. All right, so the other thing that covers ergonomics. So as it turns out, musculoskeletal disorders are going to be the most frequent reported causes of lost work. So I like these most frequent things, right? They're just fodder for you knowing what you're doing, and they're fodder for, if you want to go, I don't know, have an opportunity to excel, right? So we need to know what those things are. All right, employers, right? This is on us. This is what we have to do, right? It's all about supporting, informing, identifying, and if we can, fix the problems. That's what it boils down to. So these lists are nothing more than just protective items we're supposed to do for our workers. The workers have a right to expect safe working conditions, info training. If they have an injury, they have a right to a record review. They have a right to complain, and they have rights depending on local laws, right? You can't get around those things because OSHA is a regulatory agency. FDA is a regulatory agency. This covers, so I'm gonna take a drink again. This covers all the stuff we put into ourselves and our patients. So drugs, all the local anesthetics, all the antibiotics. All right. I saw the question about antibiotics in kidneys, and let me clarify. It is okay to give antibiotics to your patients with kidney disease. You just have to but you have to be selective about what antibiotics you use and the dosages. So to clarify that question, it's okay to give antibiotics. You may just need to lower the dose or spread it out a little bit more, especially if it goes to the kidney. So you got to know your drug. All right, back to FDA and what it says about drugs and biologics. All these devices and biologics are things we use in our patients, which means they have to be FDA regulated. You can't just go to whatever country X and say, I'm going to put this into your patients, because if there's a problem, you're in trouble. It also covers radiation. We're going to get to that too when we talk about radiation stuff. All right. So what is it about the devices? How do we figure out what the risk stratification is? So they're stratified according to classes and codes, and what the indications and intended uses are. You're not supposed to deviate from this. So what it boils down to is all of our dental materials are going to be class 1 or class 2 devices. They're low or medium risk, and they don't need any other regulation other than having the companies have got approval to sell them. For class 3 are biologics. So these are going to be things like our Emdogain and our bone morphogenic proteins and all of our freeze-dry bones. Those are biologics. They're considered high risks, which is why they have to go through additional processing and lots and things like that, right? So when it comes to amalgam, I know this is a hot topic, right? The bottom line with amalgam is it's not about the mercury in the patient. It's never been that way. It's been proven that it's safe. It's about what potentially gets into the environment. That's where the concerns have been. This is why the European Union is not really wanting amalgam. This is why Japan is not really wanting amalgam, because it's potential for mercury and mercury products to get into the water and the land. All right. Now, when we flip the coin to the CDC, that's just an advisory agency. They don't have any regulatory effect, right? We're not going to get involved with what's going on with the CDC right now, but it's all about health and human safety. Right? So since we do things on patients, CDC will say, okay, we want some things. Where they're heavily involved right now is all the personal protective equipment. And when I get to the end of this, I'm going to give you a summary. I've got the new stuff, so we're all on the same page. All right? This is what the CDC's pledge basically is, right? We're going to be good stewards of funds. We're going to make the environment healthy. We're going to make our patients healthy, ourselves healthy. Kumbaya, right? So what the CDC worries about a lot is communicable diseases. So I'm just highlighting the communicable diseases in our context in terms of the types of diseases that probably the CDC will have some thought processes. So what's the deal with all the viral diseases? They're aerosolized. That's the issue, right? So all these things like, varicella and all those, they get aerosolized. That's why it's a big issue and why you wear personal protective equipment. CMV, that's just, believe it or not, CMV, that's a herpes virus, right? When it comes to herpes, again, we know we get acute and recurrent type things. And then when it comes to bacterial infections, We just need to understand that it's not just strep and staph. All of these diseases like chlamydia and trichomonas and condylomas from syphilis, they all tend to be sort of ulcerative type diseases. And these are transmissible infectious diseases. Right now, they're treatable with antibiotics, but we try to avoid that in the first place. And then I threw up, I know it's a little off on the things, the infectious mono, you need to be aware of because that's an Epstein-Barr issue. All right. Where we get into gray areas is comparing a dental office, a freestanding dental office, to a hospital-based dental office, right? So for hospital-based dental offices and medical offices, the goal is to produce what are called healthcare-associated infections. I would encourage you to apply these same rules to your offices, even though like the Joint Commission doesn't cover you in a private practice, right? So the idea is if you do a medical surgical intervention, which we do, right? We just don't want to have patients get infections from them. That's why we use sterilized instruments. That's why we wear gloves. When we do sterile procedures, we use sterile water, right? What they're really trying to promote is central line, catheter, surgical site, and ventilator associated infections. That's what they're really trying to do, right? But I think we can be good stewards and try to prevent surgical type infections, even though we understand that the oral cavity is not a sterile environment. And that's what we have to have discussions with our nurses and our physicians and our healthcare providers, all right? So the good news is over the last couple of years, we're trending down, right? The number of catheter associated infections, the number of highs and other things we have is going down. That's the bottom line behind this slide. So if you put those things into your practices and you follow good sterilization guidelines, you're going to reduce the number of highs. You will. Your highs will become lows, okay? And we do this by using standard precautions. Now, important point, we do not use the term universal precautions anymore. That's an outdated OSHA term. OSHA doesn't use that. It's standard precautions is the correct term. What is that? Hand hygiene, number one way to prevent the spread of infections, right? We're going to talk about the 20-second rule. I'm going to show you a slide that says 15 seconds. We're going to talk about why it changed. Using PPE, cough etiquette, right? Even when I'm sitting home here, I cough and I tend to go, right? Because I don't want to cough into the screen and get my computer virus, right? Sharps, injection practices, and obviously sterilization and disinfection. And the environmental issue tends to become more along the lines of potentially infected amalgam and infected materials. All right, easy peasy. Single most critical way to reduce the risks is hand hygiene. Wash your hands, right? I have next to me in my office here, I actually have alcohol-based hand rub. All right, so this is where there's a change. So when I pulled the 2003 CDC guidelines up, I did not change this for this presentation because this is what we used historically. The new guidance is minimum 20 seconds. That's the only change here. When it comes to surgical antisepsis, it's 2 to 6 minutes. So if you're doing a surgical, so like think surgical scrubs, all right? So change 15 seconds to 20 seconds, change surgicals, leave it the same, 2 to 6 minutes. Okay. So what we have to do is we have to provide a place for our staff to wash their hands. That's easy, right? And it's supposed to be done after you remove your PPE. And I'm going to talk about at the end what differences it is in the COVID associated environment, just so that we're complete, right? But you take off your PPE and you hand wash immediately. There's no waiting, all right? When it comes to personal protective equipment, it's all about risk, right? Sorry, my slide's a little off here. My font's changed size, right? So it has to do what you're doing. If you're just doing a dental exam, then you're probably okay with gloves, face mask, and or a face shield. If you're going to do splatter type stuff, then you're going to add things like gowns and face shields, and under COVID guidance, you're going to add an N95 respirator. Okay, that's what that boils down to. All right. So what do we have to do? OSHA, who is a regulatory agency, so they say we do. They say you have to provide PPE. The employees don't pay for it. We do. It has to be hypoallergenic if possible, in case your staff's latex allergic or other allergic. And then your stuff is not supposed to leave the facility. You know, people walking out with scrubs, that's a no-no. All right. It has to be laundered or disposed of in your facility. Taking a drink. Cover your cough. That's what it boils down to. It all boils down to cover your cough because a lot of these things, including COVID and herpes and all the other colds, they're respiratory borne. So what does the N stand for? It's the percentage of things that get filtered out. So minimum standard is N95. If you can buy N100s, that filters everything out, but you're probably like, working in like, the lab where the Walking Dead formed at, right? Okay, what about sharp safety? Bottom line, no two-handed techniques, period. All right, accepted forms include one-handed scoops and mechanical devices, period. That's what this slide boils down to with sharp safety. Injection practices doesn't necessarily apply to us, but if you're in an office where you have multi-use vials, the recommendation, it's actually not recommendation, it's actually a requirement, you have to fill your multi-dose vials out of the patient area, and you then have to label the syringe appropriately before you put into your patient, before you don't want to have like a wrong kind of injection. Like, if you've ever seen the videos where the woman talks about the baby and the baby got heparin, unfortunately, and died from a massive hemorrhage, right? So we like single-use devices. It's recommended that if the FDA to use single-use devices. If you work in a hospital, Joint Commission will tell you to use single-use devices as well. Otherwise, you got to do it outside the patient area. All right. When you're done with all of your stuff, then you have to figure out how you're going to deal with sterilization and disinfection. So you have to decon first. All right. We're going to talk about the fact that there's basically mechanical scrubbing, which we go against because of potential injuries, and then there's actual ultrasonics. And then when you actually sterilize, I'm going to get to the numbers, and we're going to probably get confused about this temperatures and everything. Once you sterilize and package, event packaging it's event related, not time related. So as long as you don't have contamination, in theory, your sterilized packs can last forever. So it's event related, not time related, unless they're contaminated. But your storage has to be under some controlled humidity areas. It has to be less than 70%. That's the big one, right? Because if they get wet, then you can't vouch for things. You have to re-sterilize. So when it comes to the types of devices you use, this is where it gets busy. So let me summarize for you here. It all has to do whether the items are critical, semi-critical, or non-critical. Critical is the things that go into your human body, right? That's going to be hips, implants, surgical tools that you use to cut. Semi-critical is just stuff that comes into contact, right? So it'd be mirrors and things like that. Non-critical items are going to be like things like your blood pressure cuffs, right? Or maybe you're just whatever, you're I don't know, you're doing like the forehead touch temperature type things, right? Based on that determines the level at which you have to disinfect things. So for the typical like environmental surfaces, like your countertops and things like that, probably low level disinfection is okay. But the problem is they won't inactivate resistant organisms. So hospital disinfectants are usually considered low-level disinfectants. If you have a disinfectant that will inactivate some vegetative bacteria and some viruses, then they become intermediate level. But the problem is that will not affect spores. So in order to get spores, you either have to have a high-level disinfection or an actual sterilization. And the problem with high-level disinfectants is not every spore gets killed. So the reason we choose sterilization and we choose spore tests is because that will verify that we're killing everything, including spores. That's what it boils down to. So yes, you can use intermediate and high-level disinfection for your low risk and intermediate risk things, but when it comes to these critical items, you must sterilize, period. That's what this all boils down to. So this is the table, and this was right out of the CDC guidelines from 2008. So critical, sterilize, semi-critical, high level, non-critical, your countertops, you can do low level, period. All right. Any device that's heat tolerant, the CDC recommends, but remember, they're an advisory agency, not a regulatory agency. They recommend that you sterilize, right? Now you might have to use dry heat for things like your OmniCams, but they recommend that if you can do it, do it. All right. What about the temperatures, right? It gets very confusing here. I went to the CDC website, and I'm going to read you the numbers directly off of the CDC website. 121 degrees Celsius or 250 degrees Fahrenheit for a minimum of 30 minutes on a gravity displacement type unit. If you up the temperature to 132 or 270 degrees Fahrenheit, depending on the type of pack you're using, it can be as short as 4 minutes. in a pre-vac type scenario. So the idea is if you turn it from 250 to 270, you can cut from 30 to 4, but you always have to follow the instructions for use based on the device and the packaging. That's the bottom line. So there's different numbers here for dry heat, right? But that's dry heat, which is why steam is the preferred method, because steam and pressure allow you to work at 250 or 270 for 30 minutes or so. Dry heat requires higher temperatures and more time, which is why your OmniCams will take longer to go through, period. All right. So when it comes to using disinfectants, the big question always becomes bleach versus quaternary ammoniums. And what you need to know is that bleach at 5 to 25% is an intermediate level disinfectant, which means you could use it for semi-critical items, but critical items and semi-critical items will not be addressed with a quaternary ammonium compound. It just won't, because that's considered low level. That's the purpose of this slide. So these are the things, and if you notice, at 250, most things are going to be 30 minutes. At 270, it really depends whether it's gravity displaced or pre-vacuum. And that's why you have to look and see what your device is. That's why most, like most of our large hospitals, they prefer pre-vacuum systems that run at a minimum, of 270, because then you can run your instruments over shorter periods of time. All right. So once you sterilize them, you actually have to do monitoring, and the monitoring is either going to be mechanical, chemical, or biological. So mechanical just means you read dials. It doesn't guarantee sterilization. Chemical also doesn't necessarily. Your peel pack things that change color from blue to purple, that doesn't guarantee. What guarantees you is a biological indicator like a spore test. Now, we talked about minimum standard. Minimum standard is at least weekly. I get the question a lot. Well, can I sterilize every day? You can sterilize as often as you like, as long as it's at least weekly, right? So if you want to do every day, that's okay, right? That will cost you more time, cost you more money, but if it's your patient safety is worth it, I think your patients would appreciate it. The spore test must be one of these two bacteria, Geobacillus S or Bacillus A, and it depends on whether or not using autoclave or dry heat. So it becomes a memorization kind of thing. All right. I mentioned that everything is event related, as long as your integrity of your peel packs and everything is okay. If you have, if you find rust inside your device, inside your sterilizer, or you find liquid, or you find the peel packs are wet, re-sterilize, and make sure you have your sterilizer inspected. All right. So when it comes to these non-critical surfaces, right, a clinical contact surface, you can actually use an EPA registered low-level disinfectant, right? So a clinical contact surface, right? Your switches, your knobs, it's okay to use quaternary ammoniums on those. Housekeeping surfaces, you can actually use detergent and water. But once you hit semi-critical, right, then you have to use at least an intermediate or a high-level disinfectant. So that's why quaternary ammoniums are not good for the things you're going to put in your patient's mouths, right? But you need to be aware of the same rules that apply to latex and all those other things apply to your things you put in. So you have to be aware of allergic contact dermatitis. Latex gets the most attention because it causes immediate hypersensitivity, but you need to be aware of the fact that some of your patients may be sensitive. It's also why you're supposed to wear gloves when you use Cavicide, because those can cause contact dermatitis. That's what it boils down to. So there's a list of items here that are potential allergens in the dental setting. So it's just there for your kind of information, right? We come back to this again, right? So I'm just reviewing. You just need to be aware of what our potential hypersensitivities come from, right? So latex type 1, most of our dental materials and agents going to be type 2 and type 3, and then things like powder from our gloves and so forth is going to be type 4. That's what it boils down to. Sorry again for the slide being a little, I checked the PDFs that you have a handout, they should be better. All right, so bottom line, latex safe clinics, right? I'd use hypoallergenic materials. All right, so the list is here for you. And this overrides everything, right? So you can actually subscribe to one source. I have no vested interest in them, but no matter what, because people will ask me, like, what about this device? Or what about that thing? What if I use this OmniCam? What if I use the blue cam? What if I use this? It's always the instruction for use, right? So you can spend all day trying to figure out which device and which one and what number and what temperature and so forth. Follow the IFUs, right? And I can tell you OSHA, and I can tell you that the FDA, and I can tell you that the AMI folks, and I can tell you that the Joint Commission will also say, if you're following the instructions for use, as long as they meet the minimum standards. If they don't meet the minimum standards, like if the instruction for you says, just throw it in like a 100-degree oven for 10 minutes, then you shouldn't be using that product. Okay, that's what it boils down to. Okay, we do drive towards single-use devices, and we're going to get to this in the context of handpieces and burrs in just a minute. So the first thing to realize is the FDA defines the regulatory requirements, which means they say we do. So that's the first thing. So if they say single-use devices for certain things, you have to use single-use devices. It's wickedly expensive, but if they say, we do. All right. So when you look at those, when you go to the FDA, there's actually a whole set of things. You have to look at what the product code is. And if they have D codes, you can't reprocess them. So that's going to affect a lot of our diamond burrs. But if they have N codes, they can be reprocessed. So I'll show you two examples. So this is like a Profin kind of burr. It has an EFB code, so that means it's reprocessable. So these would be things like your carbide burrs and things like that. You can sterilize them and use them again. But your blue-white diamond burr, for instance, that's just an example, that has a D code. So you can't reprocess that. You're supposed to dispose of those. It gets wickedly expensive if you're a prosthodontist doing a lot of fixed dental prosthesis. We know that, but you can't reprocess them. You're supposed to dispose of them, period. And it's an EPA issue. And if the EPA comes into your office and finds you're not doing that, you'll have to answer for it, all right? So when it comes to non-reprocessable diamond burrs and injection needles, can't use them again, right? Carbide burrs, you can. And there are a subset of diamond type coated carbides that you can. So you got to look at your things and see what the code is, period. So if you go to the FDA, you type in FDA device codes, I believe that will allow you to look them up, all right? What about dispenser devices? When it boils down to it, dispenser devices are okay to use, but your technicians and assistants are supposed to load them away from the patient, and you're not supposed to put that little composite gun inside the patient's mouth. If it does go inside the patient's mouth and it doesn't, and you're also supposed to have a little plastic cover on it, right? If that goes inside the patient's mouth, now that becomes a semi-critical item, and now you're going to have to disinfect it with at least an intermediate or high-level disinfectant. So that's why you should have you develop flow with your dental assistants. And don't reuse the dispensers, right? So if you had a little composite plug for a patient, really you're not supposed to reuse those things, right? You just single-use disposables, use your A2, and when you're done, get rid of it, okay? Dental unit water lines. There's no way to get around this. The magic number is actually 500 colony forming units. It's less than or equal to. It has to be potable drinking water for you to spray it into patient's mouth, period. Okay, so it's always the EPA standard, and it's an EPA standard, which means EPA says we do, right? Period. So that's when you're testing your water lines. If you have 501 colony forming units, you take that line out of commission and so you can actually address it. Whether you're going to flush it, bleach it, it's according to the instructions for use. You got to get the manufacturer together, right? Period. So if your manufacturer says you can shock it with hypochlorite, okay. If they say you can't, if it has to be a silver pipe system or if it's something else, you got to look at the instructions for use, right? Films, radiation. I mentioned we're going to talk about this. Bottom line, fast speed, F speed if you're still using films, or digital radiography, period. All right, that's how you reduce radiation dosages to everybody. All right, and you should follow LAR, right? We saw this on Friday, right? So we get in a habit of doing bite wings every 6 months, every 12 months. You really should follow the ADA recommendations. You don't have to because it's a recommendation and they're not a regulatory agency, but you should follow those guidances. So your low caries risk patients may not need a set of bite wings every 6 months, unless they're kids and they're growing and they have closed and overlapped contacts. When it comes to panos, it's all about growth and development. So you should follow these guidelines. All right. When it comes to getting exposed, your requirements, and this is OSHA, so once again, regulatory agency, they say we do. You have to have an exposure control plan. It has to be posted for your employees to see, and it's on you to, at least you have to offer them hepatitis B vaccine. They don't have to take it. Now you can make that as an exclusion if your risk in your office is high enough, but you have to at least offer it to them. And if they get if they have an exposure, you have to walk them through that process and give them an avenue. You know, for us in the military, it's a trip over to the ER, right? You and hopefully the patient, all right? And then you got to do an annual review, and your employees have to be able to see it, feel it, touch it, live it, learn it, love it, and ask questions about it, okay? You have to determine what your risk is. So if your front desk staff is low risk and they're never going to go near patients, then they have a different set of rule sets. I encourage you to just treat your entire staff the same. Offer them all the personal protective equipment if they need it, especially in coronavirus, right? Again, it's standard precautions, not universal precautions. Engineering controls, those are like the work devices and the needle cappers, right? And then we'll talk about what actual workplace controls are, the process and things we do. And you have to keep a sharp log if there's injuries, and you have to keep training records for 3 years, period. Okay, that's the magic numbers. All right, about hepatitis, we hit this again, right? So A and E is fecal oral, B, C, and D is basically percutaneous and sexually transmitted. A and B have vaccines. You can't get D without B, so if you get vaccinated for B and you're immune to D. A and E, just stay away from the yellow water. All right, and then C is the one, this is why we follow universal precautions, because we don't really know how to get around that just yet. All right, so knowing a little bit about your interpretations, if they have surface antigen, that means they're infective. So if you've got a patient and you're seeing him and he says, I had hepatitis, and he's got a report said he's surface antigen positive, shouldn't be seeing that patient yet. He's got to get over his disease first. If he has surface antibody, he's immune. If he has core antibody, he's probably still infective. And if he has antibody against the core and it's IgM, that means that he's had a recent infection. So what you're looking for is surface antibody positive. Surface antibody positive, that's immunity, right? And it looks like this, right? So you want surface antibody positive, right? So that's the one, basically the left table, bottom two areas, right? Engineering controls are the devices that we use. These are our needle cappers, right? These are our hand washing facilities. These are our eye washing stasis. Practice controls are the processes we use using the needle cappers, scoop techniques, right? Having a bin for your laundry. Don't eat in the work areas, all right? And then we need to discuss the elephant in the room. And I promise we're almost there. I got about another 5 or 10 minutes tops. We're going to get there. All right. So what's the big deal about amalgam? First of all, it's a class 2 device, which means it's one of those low, threat devices, right? The issue is all about environmental mercury, right? And as it turns out, the vast majority of mercury issues are still in industrial plants, but we're the next most common mercury users. So before you have these difficult conversations about, do I take out all my amalgams, everything else, the best place for that mercury is to be trapped up in the amalgam once it's in there, right? But because of this, you have to adjudicate the environmental perspectives of mercury. So what it basically says is the Minamata Convention wants us to separate the amalgam. So the Minamata folks got together in 2013. EPA said, as part of our Clean Water Act, they say you have to have amalgam separators. Right? If you're not running amalgam separators in your office, I hope the DEP doesn't show up on your door. Excuse me. And all these devices, regardless, have to have an EPA registration number. So, if you buy a device or a material that doesn't have an EPA registration number, you probably should send it back. All right. Where we find information on all these substances is basically in what used to be called MSDS. The correct term now is SDS. And what it boils down to is you must make it posted, whether it's electronically or in a notebook. It must be accessible to your employees and in theory to your patients if they ask. And if inspector comes in, you should be able to say, yes, it's here on my computer, let me show you, or yes, it's here in the laboratory here, let me show you, right? You should be able to show it to them on demand. And your employees have to be trained, right? Don't pour the methyl methacrylate into the alcohol and drop a match in it. We're not doing Molotov cocktails in our things, right? You have to know what to do and what not to do, all right? So what it boils down to is we have that play between the dental, I've overlaid here, right? We have the play between the dental staff who are protected by OSHA, the patient who has some protections under CDC, and the environment, which the EPA says, right? So it's interesting is the CDC only makes recommendations to protect our patients. The OSHA and EPA actually make rules that we have to follow, all right? So I'm gonna skip the review questions because I wanna just hit a couple of points just to reiterate things. The first point I wanna hit is the magic number for water lines, and that's less than or equal to 500 colony forming units of heterotrophic water bacteria. When it comes to sterilization, I want to hit once again that the magic numbers from the CDC site, and that would be the area I would probably go to first, is 250 degrees for a minimum of 30 minutes in a gravity displacement situation, and 270 degrees or at 4 minutes for a pre-vac. If it's not a pre-vac, it's going to run up to 15 or 20 minutes. All right, I got two note cards here I'm going to show you for clarification's sake. I just want to talk just one or two things about COVID so we all know we're on the same page. The CDC has changed the fever to anything equal to or over 100. All right, we tend to use 100.4, but the magic number is 100 degrees. That's considered a fever in the context of a patient at risk for COVID. Provider PPE, and we're talking about aerosolized procedures. Eye protection, right, has to cover eyes, nose, you have to have something protecting your eyes, nose, and mouth. So your nose and mouth is going to be a respirator for an aerosolized procedure, a surgical face mask for non-invasive procedures, and then a face shield or face goggles. As for any other social distancing, 6 foot is still the magic number, okay? And what the CDC recommends, and I'm just going to read you the list, consider elective delays. I know that's a problem for us in dentistry. Consider teledentistry and triage where you can. Screen and triage everybody that walks in your door, okay? You probably should be doing temperatures on them. If your healthcare providers are sick, tell them to stay home, all right? Use what are called universal source controls, and those includes masks, shields, and N95 respirators. And then obviously keep your distances 6 feet. All right, last thing I want to talk about is putting things on and taking things off, and then I think we'll break and let some questions go. Donning, putting on your stuff. This is off of the CDC site. First thing you do is hand hygiene. Magic number is at least 20 seconds, right? That's the new correction. So I gotta take a drink. So wash your hands first. Gown comes on next, followed by your surgical mask or respirator, followed by your eye protection, followed by your gloves, and then you enter the room or the patient. When you take things off, everything below the neck comes off first, and then you wash your hands, and then everything above the neck comes off first. So the order is gloves off first, gown off next. You're supposed to take your gloves off inside out, and then you're supposed to wrap them inside the gown as you take it off. You then exit the area and perform hand hygiene minimum 20 seconds. Then you take off your eye protection. The last thing that comes off is because you've already left the area is your mask or respirator, and then you're supposed to perform hand hygiene again. That's a CDC recommendation, all right? I'm gonna ask questions about HEPA filters. That's a recommendation from the CDC, but not a requirement. And I get asked questions about UV germicidal irradiation, the UVGI machines. That is also a consideration or recommendation, but not a requirement, okay? So because I don't want to overload your brains any more than we're already overloaded, I'm gonna break here and I'm gonna stop sharing my screen and I will take questions. And again, I thank you all for your attention with our little burp before. Chris or Dr. Kroll, over to you. And I'll turn my
Can N95 masks be reused if left in open air for 5 days?
Oi. I'm going to punt on that one. And the reason for that is because that's an area of contention. And differing states and differing agencies, the general recommendations don't reuse them, right? The general recommendations that I've seen is if you're going to reuse them, there's supposedly ways to put them into a sealed plastic bag, and supposedly you can autoclave them. But the answer is I don't know. And what I would encourage you to do is follow the instructions for use. Call the manufacturer if you have. And then honestly, probably the best thing to do is call your state boards or state facilities and ask them what the guidances are. There really is no answer for that. I wish I had a better answer for the question for you. I hope you don't get anything like that because we're still learning as we go. So, but I think the general recommendation is if you don't have to reuse them, I know we have to, try not to. All right. If you can avoid touching them. So I've seen one of the procedures, and I mean, Dr. Kroll might be able to address this because I've seen the video that his company put out, right? And what they do is they actually put an N95 on, and then they put a surgical mask over it. And then you eliminate some of that stuff because then you pull the surgical masks on, which are a lot cheaper. So that's one way to do it as well. And if you put a face shield over, you're going to also protect your mask. That's about the best answer I can give you. Sorry.
On a deserted island, give one passbook that you recommend.
Something with pretty pink and purple pictures in it. I'm not allowed to endorse anything. If you're on a deserted island, I think pathology is the least of your problems. So something with lots of pictures, right? By the time, and call it Wilson. Name it Wilson.
Why does my OSHA HIPAA consultant insist I stamp all my sterilized packages with a date if it's not date specific for sterilization? Just curious.
Because I can answer that one actually, because I actually helped write some of our guidance for our institution. So even though it's event specific, if you have an event and you've released those instruments already to a patient, you then need to go back into your sterilized room, and everything that has that date, you pull those. That's why. It's the same reason why you use lot numbers if you're smart on all your devices that you put in, like implants. So if there's a problem with one implant in lot number 674-211, you pull all those. That's why you use the date. That's a great question, right? So yes, it's only if there's a problem. It's just like if you have a sterilizer run number and you know that your first run of sterilizer was great, but your second run of sterilizer, it didn't reach temperature, and you've released those instruments to those patients, you got to pull all the rest of the instruments, and then you're supposed to notify your patients. Hey, we can't guarantee that this was sterilized, but here's what we're going to do to fix it. That's a fantastic question. Thank you for asking that one.
Are you saying all diamond burrs are one use only?
Again, it depends. So the diamond burr is one use only. It depends on the code. If they have a D code, yes, they're supposed to be one use only. And the problem we have with that now is that's now an FDA recommendation. Trust me, Dr. Kroll can tell you our companies are going around and around on that still. So I would strongly encourage you, even at the higher cost, if it's a D code, if it's DFZ or one of those, single use, toss it when you're done. You hate to do it. By the way, it goes in a sharps container if you're smart, right? But if it has an N code, you can reprocess it.
What about curing lights? Use intermediate level disinfectants?
So the answer is, and Dr. Kroll, if you want to jump in on this one too, the answer is that's possible. It's feasible, right? Because what does that curing light potentially do? Is it potentially touches a mucosal surface or a tooth. So that's semi-critical, right? So in theory,
I agree with you, Dr. Klingman. Usually, if you look at your manufacturer's instructions for use on your curing light, they're all going to have different guidance. Some of them will actually tell you to use an intermediate level disinfection. Some will tell you to use a high level disinfection, like in an immersion if the tip is removable, and others will recommend a barrier. So usually when it comes to, even for our companies, which tend to be a little bit more strict on infection control, what we typically say is, if the instrument is not able to be processed in a dry heat sterilizer or a steam autoclave, then intermediate level disinfection along with a barrier is the recommended mode of infection prevention.
And I'm tracking that way as well. Yeah.
Yeah.
Because you're talking about semi-critical. So again, quaternary ammonium, no. Bleach, yes. Cavicide, yes. Okay, those are all okay. Thanks.
Does OSHA have any regulations or guidelines regarding employees, dentists exposed to amalgam, whether placing or removing?
I'm going to answer that question the same way I can get you to answer that question is, and maybe we can do that during the break or while Dr. Kroll's talking. I probably would have to go look up at the OSHA guidance. I don't know that guidance that specifically. I think as long as you're following the instructions for use of amalgam, and you know you're not playing like ping pong balls with the mercury, you're probably okay. The nice thing about most mercury, as long as you're not, we definitely hand mix it anymore, no more. But I think if you're using the ampules, you're probably okay. It's just like any other environmental agent and so forth. But I don't think I'm not aware of any specific monitoring or any specific additional things. Are you, Dr. Kroll?
No, the only thing, and again, I can just speak from our company's perspective. Dr. Klingman and myself both work for an employer that tends to take any sort of environmental risk, whether it's to our patient, our ancillary staff, or our doctors very seriously. Our recommendation and clinical practice guidelines for removing amalgam typically state that it should be done under rubber dam isolation with high evacuation suction, proper side shield safety glasses for our assistants, and make sure we don't overheat the amalgam, so using copious amounts of water. So,
and separate the amalgam out of your traps when you're done.
Correct. So whenever we remove amalgam, it's always under rubber dam isolation. So that way, even when we're doing a crown prep, if it can't be rubber dam isolation, it's isolite, cotton rolls, and when those cotton rolls are soaked with amalgam waste, I'll actually put those in my amalgam waste containers. So.
Same for us. Great question. Smart group here.
Are washable gowns still acceptable or should be disposable?
So I looked at the CDC guidance, and they said as long as your gowns are not visibly soiled, you can reuse them. But I think the wise thing is to just treat those as disposables. You shouldn't be washing things because you just don't. There's no long-term testing on any of those things. Once you wash, what's the integrity of that gown? It's the same thing for your lead aprons. If they're damaged, don't reuse them.
If you reuse gowns and masks, the order does not work quite the same, right?
Right. The trick for that one is if you're going to reuse them, try not to touch them, right? And that's so hard to do as I sit here and scratch my nose, right? So my wife's always like, don't touch your face, don't touch your face, don't touch. So I do this and I go, I'm gonna touch my face, right? So I think it does change the orders. I'm just reading you what's a standard CDC protocol guideline for when you're disposing of your surgical masks or N95s, which is why I know some people are choosing to put surgical mask over it, because then you can dispose of the surgical mask, right? And you just don't touch the mask on your face, right? And you shouldn't be touching your face anyway until the very end of the day, right? When you go
Are N95 and K95 still interchangeable? Similar protection for aerosol procedures? And can you put surgical masks over them to extend the life?
Ooh, I'm not 100% sure on this because they seem to change that. It's a moving target. It's an IFU kind of issue. Just order your mask through a reputable company, I think. So I'm not, I honestly, I don't know for sure because it really depends on who's making the K95s. Half the people say, yes, you can interchange them. Half the people say you can't. I just don't know if the K95s are tested at the same level as the N95s. I wish I had a better answer for you.
Are there OSHA recommendations for laundering providers' PPEs in the dental office? Can it be done with towel sheets that are used on patients while performing aerosol producing procedures?
So it goes back to my statement. I don't know that there are specific OSHA guidances related to dentistry. That's the problem. They write it for general workplace. So the answer is a judgment call, I think. I might encourage you, anything that's associated with patients. So if your patient's towels are patient towels and you want to wash them with the scrubs and you're going to wash them in an appropriate wash setting, right? Obviously, it's probably hot water with a decent detergent. You're probably okay. All right. But again, follow the IFUs. And that's when you might want to actually engage your state agencies or you might want to dive a little deeper on the OSHA stuff. Otherwise, we could be here, with every regulation under the sun. But I'm not aware that there's a specific guidance that you can't wash both together.
The problem with dating sterilization bags is that it takes almost a week to get the spore test results back. Do you suggest a mail-in service for this, or what do you recommend?
So we're not supposed to make individual recommendations. I would say find the fastest way to do it and use that if it works for you, and you're able to adjudicate that with your finances and how much it costs you to run your practices. So yeah, I mean, when we work in big industrial companies like ours, we can sometimes get results back very quickly. I don't think it's a bad idea. I really, it's making a specific recommendation is kind of crossing a no-no for us. So,
are there any specific guidelines for storing the sterilized instruments? Can they be stored in an area where we are storing inventory?
So most guidelines that I've seen says you should not be storing sterilized materials with non-sterilized materials. We get that all the time with our drawers. So the answer is no, you shouldn't store it with your normal equipment. And there's a slide that I showed you before that talks about humidity. There's supposed to be some temperature and humidity controls. There's questions about positive pressure rooms, but most guidance I've seen, it should be at least no more than 70% humidity. So that becomes a problem in places like the Gulf Coast, some of our locations, even here in Texas, it gets humid. So it's on that slide. I don't remember what slide number it is. It'll list the, it's the one with the little 3 boxes training from one to the other. It's got the list of humidities and pressure recommendations. So, but no, you shouldn't be storing, say, for instance, sterilized instruments with your office supplies as an extreme end. They should be in a separate sterilization area. Even if it's its own cabinet. You can be in the same room, but it has to be its own cabinet.
What if you use a barrier for a curing light?
So that goes back to Dr. Kroll's comment. Ideally, intermediate level disinfectant plus the barrier. But if it's not going in the patient's mouth and your assistant is actually working those things sideways, but that becomes a problem, right? Sometimes you have to dispense your composite or your restorative material into the oral cavity. Then again, the ideal is you should pull the barrier off and then do an intermediate level disinfection, right? If you can, it doesn't take very long. All right, I would encourage you to do it. But again, there's no guidance says you have to.